Good evening, everyone, and thank you for joining us for How to Take Control of Pain. This webinar is brought to you by Can Do Multiple Sclerosis. My name is Laura Allen. I'm the Director of Programs for Can Do MS, and I will be your moderator this evening. So if you'd like to, we will save about 20 minutes at the end of the webinar for questions and answers. If you do have a question during the presentation, you can use the questions chat box, which is found in your control panel. This presentation is being recorded and will be archived on the Can Do MS website. You can download a copy of tonight's presentation in your control panel, and additional resources will be found in the follow-up email that is sent tomorrow, which will have additional resources. So looking at our September programs, and Dawn, can you believe that it's September? I'm about blown away here, but welcome to September. Our theme this month is pain, which I'm sure is a common symptom that many of you share. This webinar is going to be followed up with our Jumpstart program next week, and then our YQA, or Your Questions Answered, the following week. Both of those programs will focus on pain. And as a reminder, the Jumpstart and the YQA are interactive programs. So you will have the opportunity to share along with other people with MS and our healthcare team. The other thing I want to bring to your attention is we do have the application open for one of our multi-day programs, the Can Do program. You can check it out and apply at cando-ms.org/CanDo. And that registration will close in early October. But I do encourage you, if you are interested in participating in that program, to sign up sooner rather than later. Now tonight, I have the pleasure of introducing our speaker tonight, Dawn Ehde. Dawn is the co-director of University of Washington's Rehabilitation and Wellness Research Center. She conducts randomized controlled trials evaluating cognitive, behavioral, and mindfulness-based interventions for chronic pain, depression, and fatigue in adults with multiple sclerosis. She is particularly interested in improving access to evidence-based pain care via telehealth and by integrating non-pharmacological interventions for chronic pain and headache. She is the editor-in-chief of Rehabilitation Psychology and a section editor of Archives of Physical Medicine and Rehabilitation. She chairs the Physical Wellness subgroup of the National Multiple Sclerosis Society's Wellness Research Working Group and is a past member of the Society's Medical Advisory Board. Thank you so much, Dawn, for being here tonight. It's wonderful to see you.
Grateful to be here today.
We're going to do a poll.
Yes, we're going to do a poll. So as you see on your screen, the first poll is the question, do you have pain? And go ahead and select one of the following.
And so Dawn, just so you know, I'm seeing the answers come in, and I'll close that poll in just a second. I want to give people a little bit of a chance to answer that question, and then we'll share the results. So It looks like we have some respondents coming in. And let me close that poll up, and then I'm going to share the results with the group. Any surprises there?
Not at all. It's unfortunate you have pain, although I'm going to be talking about what to do about that this evening. But as you can see, you know, many, if not most of you have pain. So I'm glad you're here with us tonight.
I'm going to do one thing. I took that mouse back for just a second. Turn my webcam off, and there you go. You have the mouse back.
Okay. I'm not seeing the slide at the minute.
There we go. You got that?
I'm seeing the poll still.
Oh, you know what? I apologize. I have to hide that. That's my mistake. Thank you so much.
Yeah, and I think the last thing I need is control of the mouse.
You got it. You're moving it around.
Oh, okay.
There you go.
Yeah, there we go. Technology. All right. Well, I'm very grateful to be here. Just a quick bit of background I want to fill you in on is that I actually started out as a pain researcher. And about 19 years ago, I became interested in MS due to having family and friends with MS. and I conducted my first study on pain. So I brought together my understanding and knowledge of pain and brought it to MS, which is really my main focus of research now. The good news in that is I still keep up on advances in pain science and apply them when relevant to MS. And it's really an exciting time to be an MS researcher and a pain researcher, because we're making considerable gains in both fields in terms of understanding and treating pain and MS. What you see here are our learning objectives for this evening. We'll be describing the types of pain that can occur in MS, and then what you can do right now to manage MS rehab or related pain, including medical, rehabilitation, and psychological strategies. Well, as you saw from our poll, pain is quite common in people with MS. And just a little science here to ground us in terms of how common it is. There was a meta-analysis published in 2013 which is a type of study, very rigorous, where the scientists put together all of the studies that have been done looking at the prevalence of something, in this case pain, and they found that 63% of adults with MS across many different studies reported having pain, with 62% of them reporting that they had pain within the last month. Similarly, in a 2015 study, in a prospective study where they track people going forward over time, Feist et al. Found that 74% had pain at some point, and 40.5% had disruptive pain. That is, pain that got in the way of their day-to-day activities. So as you can see, pain is unfortunately quite common. Well, not only do people who have pain have just the effects of kind of the discomfort of pain, but also there are many other negative effects or adverse effects of having pain. One of them that I think is particularly important in people with MS is that people with pain have a greater risk of falls, and that includes people with MS. Also, people with MS and pain have a variety of other symptoms that are made worse. Things like their sleep, fatigue, their mental health. It's very common to have, if you have pain, to have anxiety or stress or depressed mood. It gets in the way of doing social activities and roles such as being a parent or at work. And it really can also affect cognition, that is your memory, concentration. We also know that people who have pain also have a higher level of healthcare use, meaning they tend to have more physician visits, and they tend to have more medications prescribed that they're on, which I know is often a concern for people with MS, just the number of medications they might be on. It's important to also point out that pain rarely occurs in isolation. It often co-occurs with other common problems in MS, such as sleep problems, fatigue, mood changes, and cognitive changes. And all of those often can interact with one another and make other problems worse. All right, so we're on to our next poll. Where do you have pain? You'll see a variety of options here. You can also write your answer in the chat if it doesn't, if there isn't an option for you there. All right, the polls are coming in.
And you know, Dawn, I'm not sure if you're seeing the question box, but I see legs and feet. I see left side. I see legs greater, pain everywhere.
Yeah.
Feet mostly, legs sometimes, necks, muscles.
Yeah, this really corresponds with what I see when I see patients with MS or in our research studies that we conduct, that a lot of times people have pain in multiple places. They have it in their joints, they have it in their back, they have it in their face, they have it in their legs or arms. Yeah, this really is very similar to what the research would say is common. So, well, let's talk about what types of pain. Oh, here you can see the polls here. Thank you. So looks like arms and legs are our winner, so to speak, with almost 40%, followed by back, face and head, joints. And in terms of other, it's all sorts of things. Things like, let's see, legs, the MS hug, feet, pain all over, pain in the neck, shoulders, etc. So many different places people can have pain. And itching too, that is also common. All right, so let's talk about this in a little more depth. Well, what types of pain can occur in MS? What you see on this slide is really a variety of different types of pain that can occur in people with MS. And it's interesting. So it's things like the MS hug, where painful spasms in the arms or legs, electrical shock, facial pain. People often talk about pain even in their abdomen, or people might have burning, stabbing pain, muscle aches, back pain, you know, really a whole bunch of types of pain. And I think the thing to keep in mind about this is that oftentimes when people think about MS pain, they think about what we call neuropathic pain. And that's the pain that's caused by, you know, damage to the kind of sensory nervous system, pain, things such as Lermet sign or trigeminal neuralgia. However, in a study, I think as we learn more about pain and how to classify pain, we're learning more about how complex pain in MS is. So in a 2021 study that our team did and was led by Dr. Anna Kratz at the University of Michigan, only 9% actually had neuropathic pain only. So even though oftentimes people talk about and it's received the most research in MS, neuropathic pain is not the only type of pain people have. And in fact, 41% in our study of around 1,000 people had what's called nociceptive pain. That's pain that's caused by activation of nociceptors in the periphery, which I'm going to talk about in our next slide. But it's due to things like inflammation and tissue damage. That's things like pain in your joints, muscle pain, musculoskeletal things like back pain, shoulder pain, neck pain. So really that is a very common type of pain. And perhaps what's most common is that people often have a mixture of pain types. And so typically when I see people who have pain, it's not just one type of pain, it's not just neuropathic, but really a couple different things they might be dealing with. Well, let's talk a little bit more detail about how pain is processed, because that can then inform how we think about how pain is treated. So what you see here is three kind of core elements of pain, how pain is processed in the body and the brain. First of all, we have what are called nociceptors. These are nerve cells that come in from our periphery. They come into the spinal cord through our skin. We have them in our muscles, our bones, our joints, and our internal organs. And they're specialized neurons or nerve cells which detect actual or potential damage, tissue damage. So if you break an arm, for example, where your arm is broken, you're going to see there's these nociceptors, these neurons that detect that the arm is broken, detect there's damage, inflammation, etc., and going to transmit that signal up your nerves into your spinal cord, which is kind of where everything kind of gathers and then goes up to your brain. So your spinal cord is a really important part of kind of relaying pain signals to the brain. But really, the final stop for all information about pain and for pain to be processed is our brain. So some of you, and this has come up, some of you may have been told before that, you know, your pain is in your head. And I've had patients who've actually told me that they've not been believed about their pain because it's thought that they can't find, their doctors can't find where the problem is in their legs. And so they say, well, it's in your head. Well, I would say to that it's in your head only because your brain is in your head. So pain is very real, and pain is the result of really complex processing, the kind of complex network of communications within the brain that result in the experience of pain. And what you see is on this slide is a very complicated picture, but what I wanted to point out more is that if you look at the image of the brain on this slide, you'll see that there are several different areas that are in darker color gray. And these are some of the areas in the brain that pain processing are involved in pain processing. So things like the thalamus, which is kind of how the pain signals from the rest of the body and the spinal cord are sorted and then relayed to different parts of the brain to continue being processed. There's the somatosensory cortex, which tells us where the pain is and what it is. For example, the pain is in my left hand and it's a burn. We then have our anterior cingulate cortex, which really is a primary part of our emotional response to pain. And that's why pain can contribute to our emotions, things like anger, irritability, and sadness, for example. And if you think about this, this is very adaptive. If we have an emotional reaction, we're more likely to do something. So if my arm hurts because of a burn injury, I'm going to be anxious about it and more likely to seek care or to do something about it. And then finally, in our prefrontal cortex, which gives meaning and thoughts to our pain. For example, a burn on your left hand might mean I burned my hand on a stove. So we interpret what's happened. All of these different areas work together to result in our experience of pain. And sometimes they're referred to as a pain matrix. And this is really a lot of science behind this in terms of how pain is experienced. So I think it's the important thing and the takeaway is that two things. One is that there are many ways to intervene because of the different areas of the brain and body that are involved in pain processing. And many of these same areas of the brain are involved in processing of other conditions and other symptoms, things like cognition. So it's not surprising people report more difficulties, for example, with attention concentration, because some of the same brain areas involved in attention and concentration, for example, are also involved in processing pain or depression or mood. All right, so what does this all mean? Well, I want to show you just one more model at risk of making this even more complicated, because I think it's really important to understand, again, contemporary science around pain. And so I've been talking about how complex pain is. On this slide, it's just another way of thinking about pain. And this is really current thinking. If we kind of take it from the brain into kind of what does this mean? We think of pain as from what we call a biopsychosocial model, meaning that there are biological, psychological, and social contributors and consequences of pain. So for example, I've been talking a lot about nociception. That's when those neurons that involved in pain detect some tissue damage. I talked about nervous system sensitization. So the brain can become sensitized, the central nervous system can become sensitized to pain so that the brain is responding as if there's pain even when there's no tissue damage going on. So that's what I mean by that. There's social factors, things like, sorry about that. Social factors like the environment, socioeconomic status that influence pain. For example, somebody who has to work doing physical labor, even though they have pain, that might make their pain worse, right? And then certainly psychological factors. And there's a wealth of scientific evidence that shows that what we think, how we act, and how we feel influence the experience of pain. All right. So as you're thinking about it, this is just a self-assessment. We're not going to spend much time here, but I want you to keep in mind that it's always important to think about when you're thinking about what to do about pain, to think about kind of where do you hurt, when is it worse, when is it better, what makes it worse, what makes it better, and what might trigger pain flare-up, or conversely, what might help when you're feeling, help with your pain. So these are just all questions to ask yourself as you think about your pain and how to best manage it. All right, so now I'm going to talk about more about what to do. We're going to talk about some treatment and pain management strategies. All right. Okay, let's talk about medications first. Medications are the most common pain treatment used today for MS pain. And medications certainly have their place in managing pain for many people. When we look at research, the most commonly used medication for pain is actually non-steroidal anti-inflammatories, things like aspirin, ibuprofen. These are medications that are thought to decrease inflammation and as a result decrease pain. And a recent study done just a couple of years ago found that 67% of people in the study, and it was a very large study of over 1,000 people, 67% used non-steroidal anti-inflammatory medications as their primary type of pain medication. People also use neuropathic pain medications. These are things that you might be familiar with, such as gabapentin or Lyrica, and there's a variety of others that are often used to try to kind of quiet the nervous system, so to speak. Other types include antidepressants. Even people who are not depressed, we have found that antidepressant medications work for some people and help people decrease their pain and increase their ability to do things they want to do. Another one that's not listed on here, but that used to be more common, but is less common now, are opioids or narcotic pain medications. And opioids certainly can be helpful for severe pain or moderately severe pain, but in people with MS, it's always, healthcare providers tend to be pretty careful just because sometimes the side effects, such as constipation, can be difficult to manage or experience for some people with MS. And the goal really of any kind of pain treatment is to try to maximize function and comfort and minimize side effects and minimize pain, of course. So now, of course, for many people with MS, this is kind of where pain management stops. They go to their doctor, they have pain, they go home with a medication. And for some people, this is great. That's all it's needed. However, there's many times where pain is not completely alleviated with just medications alone. And there's probably a lot of reasons for that. But of course, as you've learned already, pain is really complicated. And so there's other things that can contribute and other ways of treating it. I would just mention that, if you're wondering more about medications, I am a psychologist, so I encourage you to talk with your healthcare provider who treats your MS about medication options in more detail. All right, let's talk briefly about cannabis or marijuana. This is probably one of the most common questions I get. And as you know, many people live in states now where cannabis is legal, either in a medicinal marijuana or even just for recreational use. And it's very common in people with MS. For example, a study by my colleague Tiffany Braley et al. In 2020 found that 42% of adults in the USA reported using cannabis in the past year. And just about all of them, and this isn't people with MS again, just about all of them reported that they used it to help with pain or sleep. However, only 18% had discussed it with their healthcare provider. And I'm guessing there's a lot of reasons for that. It could be that I think there's still a fair amount of stigma around marijuana or cannabis use. I use the term cannabis. That's the kind of, I guess, drug name for marijuana, or the plant that marijuana comes from. So anyway, so very few people talk about it with their healthcare provider. And I think that's a missed opportunity, because I think, especially for people who are on disease-modifying therapies or other medications, it's really important to have a conversation with your healthcare provider about all of your medications, including any supplements and other things you take. However, I think it can be hard to bring that up out of a fear of stigma, or really, some healthcare providers are a little bit cautious in talking about it as well. I think that if you want to get more information about cannabis and its use in MS pain, I would encourage you to see Dr. Ellen Bohling's information sheet on cannabis, or look for talks that Dr. Bohling has given. He is really a neurologist who's a real expert on cannabis. And I think kind of his viewpoint, based on the available scientific evidence, is that there is some potential role that for medical marijuana of research grade that is beneficial for relieving MS-related pain and spasticity. However, he also talks about a lot of this adverse effects, like impaired cognition, things like memory, concentration, risks from contaminants or inaccurate labeling, and kind of the lack of a standardized formulation. So, again, I'm not trying to advocate for or against it. I think it's just really really important to be informed, and that's what I'm advocating you be. All right, let's talk about now rehabilitation. So rehabilitation may involve a variety of interventions. It may involve physical therapy, occupational therapy, may involve seeing even a rehab physician or rehab medicine provider who's sometimes called a physiatrist or physiatrist. And they really have at their disposal a variety of treatment strategies. They also are experts on pain. Just some of the ones that they can do are listed here on the slide. So they can prescribe exercises, they can prescribe adaptive equipment. Sometimes people develop pain because of changes in how they ambulate. So if you're walking with a bit of uneven gait, for example, you might develop pain in one side, like your hip or the other knee. People who use wheelchairs and are in a wheelchair might develop pain from sitting all the time. So they really can look at kind of how you're getting around, what's contributing to your pain, and have strategies to help you adapt how you move and how you manage your pain in ways that can be quite beneficial. Another strategy, perhaps one of the most important ones, is exercise and physical activity. So what do I mean by exercise? Exercise is the kind of deliberate, planned movement that people do that's really to benefit their health. So that's things like swimming, engaging in 30 minutes of walking every day, or aerobics from sitting, yoga, cycling, all sorts of things. We know that exercise is one of the very most beneficial strategies for pain management. It used to be thought that if you had pain, that you should not move what was hurting and let it heal. Well, we know now that not moving is one of the worst things you can do for pain. And so exercise can really help you build muscle strength and flexibility. It can make your movements more functional and more smooth so that you don't develop other pain problems. We also know that exercise is good for your mood. It decreases stress and it reduces inflammation. There's also been really interesting research showing that people who exercise can be used to reduce pain sensitivity in the brain. And it can limit developing new kinds of pain that might come from inactivity, as I mentioned, or even falls. So exercise is something that I think there's just so much accumulating evidence for its benefits in MS. So we do know that regular exercise is key. There have been many studies looking at what's best for people with MS. And so kind of recently, Dr. Roz Kalb put together with a team of experts some exercise guidelines for MS that were published and that your healthcare provider should have access to. But essentially, they recommend 150 minutes or more of exercise or lifestyle physical activity per week. So that's things like cleaning, gardening, moving around in other ways. They recommend building up exercise or activity gradually. You don't want to start with too much too soon because that can make things worse. And there are really many different activities that are beneficial to people. For people who have impairments in mobility or physical limitations, it's probably important to talk to your provider first and to get guidance from them. And that might be guidance from a physical or occupational therapist or exercise scientist, or experienced an MS is a bonus. And then also your healthcare provider, your ARNP, nurse or physician who works with you. And it's really important that your exercise, again, be gradual, based on what you enjoy doing and are able to do, and safe. So, all right. Now I'm going to talk some about psychological strategies. And by that, I'm talking about strategies where we harness our brain, our mental health, or our mental strategies to benefit our health, our well-being, and certainly manage our pain. And what we know is that psychological interventions for pain do improve pain. They can decrease pain intensity, or how much pain hurts, and they can also improve people's ability to do more, keep pain from getting in their way. And there's been a lot of research that shows that psychological treatments are as effective, really, at reducing pain as other treatments, including medications, which also always seems surprising, but that's what the literature says. And we know that many of these interventions are also effective in people with MS. And this is where I've spent a lot of my time, is researching these kinds of treatments. And what you see on this slide then is kind of the model that ties it all together and what our treatments are based on. So we know that anytime there's a situation, we tend to have physical reactions, which is our in our body. We tend to have thoughts, emotions, what we feel, and behaviors, which is what we do. Let me give you an example. All right, here's one example. Okay. I'm not sure how many of you live somewhere where there's traffic. Here in Seattle, we frequently have traffic. So getting stuck in traffic is a common stressor, whether or not you have MS in our community. And here's what you might see. If you talk to somebody who who's stuck in traffic, person A, they might talk about how they notice while they're sitting in traffic that they're thinking, I'm going to be late. This is a waste of my time. They start to notice tension in their neck. Their heart rate might go up, their stomach might start to feel a little off. They might feel frustrated, irritable, angry, anxious if they're worried they're going to be late for something important. And what do? What are their behaviors? Well, they might honk the horn, they might keep trying to weave in and out of traffic to get further up. And they might, make some bad choices, accidentally cut somebody off and get in an accident. So this shows you how one person might respond to the same situation, getting stuck in traffic. Let's look now at a different person. We'll call this person Person B. Same situation, stuck in Seattle traffic. Well, they think to themselves, well, I might be late, but at least I have more time for myself. It was kind of a hectic morning, so at least I get to listen to my music, the radio, etc. They might notice that they don't really have much tension in their neck and shoulders, or at least it's not getting worse. And they don't really feel frustrated or irritated, just kind of accepting of the situation. And they might take a few deep breaths as a way to cope with the situation. They might just enjoy their streaming music or a radio program or podcast. So same situation, two people stuck in traffic. They could even be next to each other in traffic, but they have very different responses. And this is something we know is very common in people, whether or not you have MS. We can all have different reactions or responses to situations that change how we feel, how our bodies feel, and how we act or behave. So what does pain self-management then, which is based on this cognitive behavioral therapy model that I've been showing you, or biopsychosocial model, very kind of the same thing. It really involves tracking in cognitive behavioral therapy, or CBT, kind of what sensations you have, how you think about situations, how you react emotionally, how you react behaviorally or act, and any triggers in your environment that influence how you do. And here you see some of the targets of treatment. There's many different strategies of psychological treatments, or psychological strategies, I guess, or tools that can target different areas of this body, thoughts, emotion, behavior, experience. And by the way, these things interact with one another. They're not in isolation. So for example, we're going to talk here for a moment about relaxation, how that can change the body, which then might in turn change your thoughts, etc. All right, so it's time for our next interactive poll. We're going to do a brief exercise. I want you to rate your current pain on a 0 to 10 scale, and your poll options are, with 0 being no pain and 10 being pain as bad as it can be. And you can see here what you might rate it. Thank you for voting. Keep it up.
We've still got a few answers coming in.
All right. Yep, but 72% of 73% have voted. And what are our results?
Let's have a look.
All right, about 8% of you currently don't have any pain. It looks like the majority are kind of in this 4 to 6, which we consider moderate pain. And another third about in that 1 to 3 with whatever the math is, 50, 80, about 19% having, or 20% having a 7 or greater, which is pretty significant pain. Thank you for that poll. Well, let's talk about relaxation. And I'm going to have you actually do a relaxation exercise just for probably 2 minutes. It's going to be pretty quick. All right, so what I want you to do, if you feel comfortable, go ahead and just kind of get yourself in a comfortable position. And all you have to do for the next couple moments is listen to my voice. And I'm going to talk you through a very common kind of building block of relaxation exercises. Learning to breathe correctly is probably the easiest, quickest, and most effective method of learning how to relax. Even though breathing is really automatic, we often can kind of develop this habit of taking short, shallow breaths, which increases our tension in times of stress. And so one of the ways to really trigger what we call the relaxation response, which is the opposite of the fight or flight or flee stress response, is to use our breathing. We all have diaphragms. It's a dome-shaped muscle right under your rib cage, kind of between your chest and your stomach cavities. And what I want you to do is go ahead and kind of, go ahead and put your, if you can, put your hand, one hand on your kind of your belly or your abdomen and one on your, kind of more on your chest. And I'm going to ask you just to take a few deep breaths with me in whatever position you're in. Just adjust yourself so you're comfortable. Go ahead and take a deep breath in. And just notice which hand moves the most. Some people notice that their hand on their chest moves more. Other people notice that they breathe more from their abdomen. That's what we want. You want to push out your stomach. That's the way it should feel. So take a nice deep breath, trying to engage your abdomen or your stomach muscles. Okay, take a deep breath in through your nose, feeling the hand on your stomach rise as you inhale, and then breathe out from your mouth. Just letting your stomach kind of relax. And I want you to continue to breathe like this for a few moments, breathing in through your nose and out through your mouth. Nice and slow, deep breaths. It can also be helpful to think about slowing down your breathing. So breathing in maybe to a count of 4, like 1, 2, 3, 4, and then breathing out 2, 3, 4. Just pause between breaths. Breathing in and breathing out. That's right. Another one. Just keep breathing. All right. Good. Well, we're going to end this demonstration right now, but I want you to do another quick interactive poll where you rate your current pain again on a 0 to 10 scale. Where is it right now, your pain? That's right. We have responses coming in. Hope nobody fell asleep doing the breathing. All right, what are our results? Only 8% of you are in the severe range now, whereas it was about 20. And it looks like more of you moved in, it looks like a number of you just moved down a category where 15% of you now have no pain instead of 8. And many more people are in the 1 to 3 or mild pain category. All right, well, let's look at our slides again. So what I hope that shows you is that something as simple as just taking a moment out to do some brief relaxation can elicit the relaxation response, which processes in your brain and body to help you feel more relaxed and to have your pain go down. There's many different strategies. I taught you just a couple-minute one, but there's many options in one of the tools I'll talk about in a minute, including some guided recordings you can listen to of different types of breathing relaxations. This does take regular practice, and it's something I encourage people with pain or fatigue to do really every day, even when you're not in pain, because the more you do it, the more you can elicit that natural relaxation response in your brain and body, which then makes you feel better and can make your pain go down. All right, I want to talk about 2 other things briefly, and then we'll open it up to Q&A. So I want to talk about mindfulness meditation. This is something that's been around for many centuries, mindfulness meditation, but it's something that's getting more use in pain care and other forms of medical care. Well, what is mindfulness, you might wonder? Well, it's simply paying attention on purpose, non-judgmentally in the present moment. And mindfulness meditation then is simply the intentional practice of mindfulness. And what this is really based on is that so many of us are often on autopilot where we're just reacting to things, react. Something happens, get stuck in traffic, and you react. And mindfulness teaches us to pay attention to what's going on, and then to have the opportunity to respond in a different way versus react, to respond with choice, to respond with intention. And that gives us this little space where we can then do something differently in how we respond to pain in this case. And there are many different options for learning mindfulness meditation. We don't have time today to do another example of this, but I will have tools for you at the end. And this is something we've been studying just recently in our research center, and we're finding that many people find it helpful, and not helpful just for their pain, but other areas of their life. But like everything good in life that's good for you, it takes regular practice. But there are a variety of apps, classes, community groups, as well as learning this through psychotherapy that can benefit you. All right, I want to get back to thoughts for just one more moment before we wrap up here. I want to talk about thoughts. As I said before, thoughts happen in our brain, and we know that people who have pain or people who don't have pain, everybody has thoughts that influence how we feel, how our bodies react, and what we do. So one of the things we do in cognitive behavioral therapy is we teach people ways to work with their thoughts to help them be helpful to them and to minimize unhelpful thoughts. And this is just one example, and you'll get this as a handout in your email, but this is just one example of a worksheet that we use where we have people keep track of their thoughts, what their body reactions or physical reactions are, what their emotions are, and their behaviors. And we teach people how to change their thoughts, not in a way where they're Pollyanna and falsely positive, but rather just to find ways to just move their thoughts in a way that are more adaptive or helpful to them and elicit more of a relaxation response or a helpful coping response. And this is really one of the foundational things working with thoughts of cognitive behavioral therapy. And so we teach people how to recognize and label thoughts, and sometimes that's all you need. When you notice you're kind of cascading this spiral downward of unhelpful thoughts, that alone can be enough to change your thoughts and decrease the stress associated with these types of thoughts. We teach people to challenge and reframe them and to learn how to let go of thoughts. And again, there's some helpful handouts on this that you'll have access to after this. There are a lot of other strategies that are helpful that I didn't have time to cover. Things like how you pace your activity so you don't binge when your pain is good on activity and then really go bust because you can't move the next day because you did too much. There's ways to manage emotional triggers, to use stress management, good sleep, communication, all sorts of things that you can learn for managing your pain. And there are many, the good news is there are many sources out there for this. I want to share this one with you just because it really was built for and with people with MS. This is called My MS Toolkit. It was developed between my team and the University of Michigan team. And it has a variety of resources that many of the strategies I've talked about. It has worksheets, it has videos to show you how to do it. It has recordings for relaxation and mindfulness. So I would encourage you to look at this as one place to go. It has other resources as well. In terms of other resources, the National MS Society did a Managing Pain and Sleep Issues in MS program that has some downloadable and videos you can, worksheets and videos you can watch. And in conclusion then, our key takeaways. We know that pain is complicated, but it's best understood from a biopsychosocial perspective. And the bad news is it's complicated. The good news is there are many places we can intervene on to help you feel better and to help you can help yourself feel better. You have many options for pain management, everything from things you do on your own, like starting a relaxation or meditation practice or exercise, or checking out some of the tools that I've talked about already, to attending a group or seeking mental health or physical therapy to help you learn some of these in more detail. Please remember that, like everything, practice, practice, practice. And you often have to experiment. What works for one person doesn't always work for everyone. And so practice trying different things, give them enough time to see if they benefit you, and see kind of what different things put together help you best manage your pain. We have other resources that you will have available to you. And thank you. That concludes the didactic portion of our webinar today.
Awesome. Thank you, Dawn. That was really wonderful information. So we do have a few minutes for Q&A, and we did get a number of questions in from our audience tonight. One person asked, you did talk about a lot of the contributing factors to pain in the beginning of the webinar. One person asked, how do we know if the pain is related to MS or not?
That's a good question. The reality is pain happens to people who can also have pain from other causes, right? An old tennis elbow, a back injury from something else. What I would say is that it is important to talk with your doctor about what parts of your pain problem are related to your MS, because there may be specific treatments that are useful, especially like maybe some of the medications, or some of the treatments related to physical therapy. However, I would say 75 to 90% of what I talked about today, we know are helpful regardless of whether it's from your MS pain, other kinds of pain, or both. These are treatment strategies that work on have been shown to benefit people with a wide variety of pain problems, everything from migraines to chronic back pain to rheumatoid arthritis, osteoarthritis, and more, fibromyalgia and more. So I think it's really important to know that actually having MS is important, but it's not the only factor. And pain is processed in the brain probably similarly whether or not you have MS, is what we're learning. So that would be my advice, is to try these strategies and talk with your doctor about what parts might be related to your MS pain or your MS.
All right, thank you for that. I did get a couple questions about pain at night. And so the first question is, why is pain worse at night? Yeah,
great question. Most things are worse at night, right? If we're tired, our fatigue is worse, our pain is worse. It's thought that our kind of our bodies and brains are just not as resilient at night. We've kind of expended a lot of our resources, physical resources, mental resources, cognitive resources, kind of getting through the day or working through our days. Also, a lot of times during the day, you may be more active doing things and have less time and attentional focus on your pain. It doesn't mean your pain isn't there, but we know that your brain can only process so much incoming stimulation at once. And so oftentimes people find when they kind of go to bed or in the evenings when they finally get to a chance to relax is when they start to experience more pain. So there's probably a variety of reasons, but that is a really common phenomenon.
Great. The other question I got about pain in the evening is I have major electrical pain in my legs, especially when I lay down for sleep. What is an option for this?
Yeah, that's a tough one. I think that it's one that I would recommend a couple different things. I think I would, I'm going to sound like a broken record here, but I think I would talk to your provider about that type of pain, because there are some medications and some treatments that can be useful for that. And if your provider kind of throws up their hands and doesn't help you, I would find another provider to discuss it with. Sometimes people find that performing a meditation or mindfulness, relaxation exercise at night, or doing other soothing things, sometimes heat or cooling before bed, doing something like that can also help you help kind of take the edge off a bit as you're falling asleep, or if it wakes you up, using some of those strategies in the middle of the night.
Got it. Before I ask you the next question, I just do one. We did get a couple of people that asked about the resources that you mentioned in that last slide, especially. And so I want to let you know that you can download a copy of the PowerPoint presentation in the control panel right now. You can also get this resource in the follow-up email that will be sent out by the end of the day tomorrow. So you will be sent an email with these slides, or a link to the slides, and then you can also download it right now from the handout section in your control panel. So let me go on to the next question. And marijuana is such a new topic, and people are so very interested in it. So one person asked that you mentioned that marijuana can help with pain. Can it help with cognition?
Well, because marijuana has not received a lot of scientific study until recently, there's a lot we don't know about it. We do know from research that the use of marijuana or cannabis can actually have negative effects on cognition. And there have been a few studies published recently that show that, unfortunately, cannabis use can have negative effects in people with MS. So I have not seen any evidence that it benefits cognition, although certainly if your pain or fatigue is so severe that it makes it hard to concentrate, it might be one of those where you talk with your provider about kind of the pros and cons of it. Also, there's certain ingredients like the CBD versus THC. The THC is what we know has the most negative effects on cannabis, and so sometimes people report trying to find more versions of cannabis that are more CBD based, and that may be more helpful with less negative cognitive side effects.
So, and I know you touched a little bit on the marijuana and pain and how it relates. Can you talk about the benefits that marijuana gives you in regard to pain?
Yeah. Well, I think the fact that so many people, nearly 1 in 2 people with MS in the United States, in the surveys at least that I've seen, including our own survey report using it, tells me they're getting some benefits out of it, especially because they're reporting using it not for recreational social reasons, but they're using it to manage their symptoms. And there's been some scientific studies which shows that marijuana or cannabis does have beneficial effects for sleep, for appetite, and for stimulating appetite for people who have that issue, and for fatigue and for pain. So, there is evidence of that. And again, I think it's something that hopefully we'll know more about in the coming years as we study it more. So I think it varies by individual. And so again, something to really be thoughtful about and talk with your providers about, but it's certainly one option.
Thank you for that explanation. I think that you've reached out, with some great information. And so one of our participants asked about seeing a psychiatrist or a psychologist, excuse me. But the question really is, and this is something that's really difficult, is how, the paying for it part. And so can you give us any indication of insurance and how that coverage works for seeing a psychologist?
Yeah, so just not even last month, just a few weeks ago, the National MS Society came out with a mental health guidance, which we can make sure you get the resource for, that talks about how to access mental health care, including psychological care. And it talks about what to do if you have insurance, if you have problems navigating your insurance, and what to do if you don't have insurance. And it's pretty detailed. I was part of the group that put that together, and it has some really helpful strategies for navigating what can be a very challenging thing. The good news is that in many states, your insurance should cover care to see a mental health practitioner or mental health or psychologist for problems including like pain. So many psychologists are trained to help people manage pain using techniques like self-hypnosis or cognitive behavioral therapy, acceptance and commitment therapy, or mindfulness-based interventions. And so, it used to be it wasn't paid for, and more states are paying for it now. So hopefully that'll continue to get better. But please check out our guidance if you want more detailed ideas on how to navigate that.
Great. So we are just about out of time. And rather than ask another question, what I'd like to do is ask you what your key takeaways are from tonight's webinar.
Yeah, I think,
know you did talk about some key takeaways already, but do you have any additional key takeaways?
Yeah, great. Well, I'm very excited about this topic, again, not because people are suffering from pain. I wish that wasn't the case. But I'm very excited because I do think that there are many things you can do, that the science is advancing, and we are going to have more and more options for managing pain, figuring out what pain treatments work for what person. That's a new area that a lot of us are studying, so we can get you the right treatment sooner, or combination of treatments, and looking at how to kind of combine different treatments in as efficient way as possible to treat pain. So I think there's a lot of hope on the horizon, and I really encourage you to learn more and to continue to take the steps you can to manage your pain.
Well, thanks so much, Dawn. I think that you provided a tremendous amount of valuable information for our participants tonight, so thank you so very much. I do want to give a couple of closing remarks before we conclude, so let me share my screen again. Here we go. And let's see. So I do encourage you to follow us on social media. You can find out about our latest programs and resources in MS News. And you can also register for our monthly e-news series, which will provide information about additional programs. And I do encourage you to look into, if you want to get more information on pain, I would very much encourage you to join our Jumpstart program, which is next Thursday, or the following week we have Your Questions Answered. And remember, this is an open forum for you to ask questions virtually to our healthcare team. So you have the ability to ask questions directly. You can write them in the chat box over a Zoom meeting, or you can raise your hand and ask those questions directly. So if you want to get more in depth, please join our Jumpstart and/or YQA. It looks like our next webinar is going to be on how to fall asleep and stay asleep, which is a kind of a nice companion topic to what we just discussed. So that concludes our webinar for this evening. Again, I want to say thank you to Dawn. It's been a pleasure working with you this evening. And most importantly, I want to thank all of you out there for joining us. We do so appreciate that you come to our webinars regularly, once in a while, or you're new for the first time. We love you to be part of the Can Do MS family. Thank you for being here tonight, and I want to wish you all a good evening. Thank you, everyone.